we're going to focus on non-operative management of rectal cancer and also total neoadjuvant therapy, which I think everybody is talking about these days. And there were about 3 presentations at ASCO this year. So briefly, talking about the Mercury study, I think, which is pivotal in making MRI as standard of care in rectal cancer. So I'll just go through a few things which are very important for our surgical colleagues. So as you can see from this, even Gina Brown could not find that, lymph node status predicted for disease-free survival, overall survival, or loco-regional recurrence. So for node negative, see the rate of disease-free survival and loco-regional recurrence, 22% versus 17% for loco-regional recurrence is pretty much similar. So the nodes do not predict based on MRI. What predicts the most, we discussed, MRI, CRM less than or equal to 1 millimeter, EMVI, and more advanced stages, especially T3C and T3D. And this is also validated in the German trial. If you compare node negative versus node positive, and you look at the 10-year cumulative incidence of distant Mets or local recurrence, it did not predict DFS, OS, or loco-regional recurrence. The quality of surgery is very, very important. These are the slides from Professor Quirk. And if you see that if you have the plane of surgery is very important. And we discussed last time that on the MRI scan, you can define the plane of surgery. So if whether the plane of surgery is muscularis propria, intramesorectal, or mesorectal, as you can see, irrespective of stage, the local recurrence rate, stage 2 and 3, is 5 and 6%. Look at stage 3. So the local recurrence is definitely lower if you have a mesorectal excision. So pathologically defined lymph node not only affect your local recurrence rate, but they do affect it if you leave them inside the patient. So I think plane of surgery, very important that you have your pathologist photograph your TME specimen, which is done, so that you can benchmark your own quality of surgery for the TMEs that you do. So I was asked a question about lateral lymph node involvement in rectal cancer, and again, the pelvic lymph node involvement. There is a lot of discrepancy between the East and the West. I will not go through this today, but what I can do is within our WhatsApp group, what I can do is put out about 3 or 4 review articles, which are quite good, which look at the Japanese approach, which has become the Eastern approach, where, they do go for a lymph node dissection, and the approach of the West, where they do not actually go for a lymph node dissection. And the incidence based on the distance to anal margin to the anal verge is the percentage positivity you can see here. So if it's closer to the anal verge, the chances of having lateral lymph node involvement is quite high. Treatment strategies, again, you can have stage 1 and 2A transanal excision we talked about last time. The hard indications we talked about for chemoradiation or short course chemoradiotherapy followed by chemotherapy. The timing, we discussed all of that last time. Are T3, T4 tumors. In T3, you have T3C and T3D. So it's very important that, you ask your radiologist, what T3 stage the tumor is. So factors in order of importance, just revising it from last week: CRM status, EMVI, involvement of levators, T stage and nodal status is very important. The German trial we talked about, pre-op versus post-op radiotherapy. Just one of you had asked me to show the sphincter preservation numbers, and as you can see, the long-term toxicity, the surgeries at the bottom, that's the post-op radiotherapy, and pre-op at the top. You can see sphincter preservation is significantly higher, 19% versus almost 40%. 20% higher in patients who had pre-op chemoradiotherapy. And that since 2004, that has become the standard of care. And the long-term toxicity is also higher post-surgery because there's no rectum there. Possibly there is more radiation to the surrounding organs, is 14% versus 24%. So all the trials we discussed last week, I put them on a slide, and I will share the slide as always at the end of the lecture. And you can see that there are a lot of downsides. We have not had time to discuss it. A lot of trials, you did not have good quality of TME. You do not have MRI, which was mandated, or EUS, which was mandated. Same in the long course trials as well, which we discussed last time, the German trial, which I just showed you. So very few patients had the MRI done, because the first Mercury trial was published in 2011, and this was published in 2004. And the good quality TME, as described by Bill Heald, has come along. So again, you have to individualize. Very, very important. That evidence is very important, but you must know what the downsides of that evidence are as well. So we discussed that, the local failure rate in all of the trials with chemoradiotherapy is about, 5 to 8% with short course chemoradiotherapy or long course chemoradiotherapy. But the reason why our patients are failing is the rate of distance metastasis, irrespective of whether they had chemoradiotherapy or not, as you can see on this slide, is quite high. And that's why the patients, or most of our patients, are failing. It's not because of local failure, which we have, I think, got on top of with radiotherapy and chemotherapy, but because of distant metastasis. So, that's where we will come to the TNT approach, which is the total neoadjuvant therapy approach towards the end. I will just briefly discuss now. So, in all the studies we discussed last time, we talked about pathological complete response rate, which is very important, because having a clinical complete response on MRI or a PET scan is not equal to a pathological complete response. And if we want to think of a non-operative strategy, we have to try and attain a complete clinical response. And, I've had so many patients, and all of you will have also down the line, or you may already be having patients who have an excellent response. The minute their symptoms are gone, they default from treatment. And patients with low rectal tumors, nobody wants a stoma. So, they are increasingly declining to have a stoma, and this was the story before as well. So I think that is why we want to see if we can avoid surgery in low rectal or mid rectal tumors, because it would be sphincter saving and very important for quality of life. So the 4 strategies to attain a complete clinical response would be, you can intensify the neoadjuvant chemotherapy in the chemoradiotherapy arm, and we can add oxaliplatin, which is the most effective drug. The reason why irinotecan, I spoke last time as well, is not very important is because in all the adjuvant studies, it has actually not made any difference, and none of the targeted treatments have also made a difference. And so they've not led to a survival benefit. Or you can extend the interval from end of chemoradiotherapy to surgery. We saw that it increases the path-CR rates. You can add chemotherapy in the interval from chemoradiotherapy to surgery. We saw that with the timing trial. Or you can give induction chemotherapy followed by CTRT. The strategies 3 and 4 would be total neoadjuvant therapy. Basically it includes chemotherapy, complete chemotherapy, and chemoradiotherapy. Because the doses of chemo that we give with the chemoradiotherapy, for example, I'll tell you, the dose of capecitabine is 825 milligrams per meter square twice a day. But when we give it alone with chemotherapy, it's about 1,250 milligrams per meter square. So the doses are completely different. And you also add oxaliplatin when you give chemo alone, either with FOLFOX or CAPOX. So I think these are the main trials. I will not go into details. The references are at the bottom. If you need any of the papers, just put it on the group. And I have all the papers. I can send them to you. Basically, this showed that adding oxaliplatin to chemotherapy, that is capecitabine or 5-FU, made actually no difference to the path-CR rate or disease-free or overall survival. There's a longer interval between end of CTRT to surgery, increased path-CR, and we discussed the Grecar study last week, 7 versus 11 week, which was a well done randomized trial, and we showed that, And Leon trial was the first French study which showed that, 2-week versus 6 to 8 weeks, there was almost a doubling of pathological complete response if you increase the interval between the end of CTRT versus surgery. The timing trial, again, we saw that, long course chemoradiotherapy, it was interspersed after the end of chemoradiotherapy with 2, 4, and 6 cycles of FOLFOX. And as you can see, the PathCR rate has gone up from 18% to 38%. So the neoadjuvant chemotherapy, again, Avacross was the only study with the addition of bevacizumab to capecitabine oxaliplatin, which showed a PathCR rate of as good as the timing trial of 36%. So these were the trials which were done into early 2000. The results were published between 2010 and 12. And I think the results that this now are the recent studies, and the recent studies are quite good because most of the staging is done by MRI and actually mirrors the clinical practice that we have today. So the whole point is, can we avoid surgery? And Professor Dr. Angelita Bhawna from Brazil was the first person to actually start talking about it. And she's published various papers starting from 1998 to last year as well, where she's shown that, with all patients in Brazil get long course chemo radiotherapy for, these are all low rectal cancer, that is less than 7 centimeter. And the complete clinical response rate ranged from 20 to 40%. And very impressive results. The local failure rate is about 3 to 6% and no effect on disease-free or overall survival. I think it's very important that she has selected patients which were low rectal. They were all palpable to the finger so that, it was easy to examine the patient. So remember, when you have a patient with rectal cancer, clinical examination is very important. And the more patients you see, you will know what the rectum feels like after the patient has completed chemoradiotherapy and, after or when they've had the tumor. So very important that you get experience with a clinical examination. All of these were candidates for APR. They were routinely offered. And I think she set out to avoid APR to begin with very close and meticulous follow-up. These patients had monthly clinical examination, scans, and also biopsies done. And I'll talk about why biopsies should not be done. So these are the various watch and wait studies. And I think all of these, the downside is most of them are retrospective and also single center. Most of these patients were clinically followed up. And in the recent ones, they were followed up on MRI scan. And if you look at the overall survival, it's quite impressive. So it makes you feel that, possibly we could offer it to our patients to avoid surgery. Now, how are we going to find out if the patients have had a complete response? So like I said, CCR is not always equal to PathCR. So rectal exam, the most important, endoscopic assessment, you can do a PET scan. But again, post radiation, there may still be activity post radiation. So it may be sometimes difficult to assess whether the tumor is dividing or it is just residual. Biopsies of the tumor bed and MRI are the two other options. And MRI, I think, is a non-invasive test, easy to do. Biopsies, I think we'll talk about why we should not be doing. So if you look at this slide, which I borrowed from Professor Brown, you can see that the tumor has regressed by almost 50%, and you can assess fibrosis and what she has done is she's like we have in pathology, we have tumor regression grade. She has correlated the same tumor regression grade and correlated each of the MRI scans with the pathology very meticulously. And she has published this and shown that if you have an MRI TRG from 1 to 3 versus 4 to 5, you have a favorable prognosis if you have an MRI TRG of 1 to 3. So these are the patients, if you have a TRG of 1 to 2, where you would feel confident that, possibly we can observe these patients. what she has shown, and you can see that she has validated this in all the trials that have been done at the Royal Marsden and nationally within UK, that there is good reproducibility and good inter-observer radiology agreement as well. And she's shown that this is a prognostic and a predictive marker. So in Expert C trial, they identified 40% of patients with MRTR 1 to 2, and their survival was almost 90%, compared with only 15% pathological CR rate. So, you actually could, if you go by MRI, you could possibly avoid stoma in about, I would say, 15% more patients. So why should we not do a biopsy? I think quite a few centers do it. And the reason is, biopsy only gives you a snapshot view at that time point, does not tell us whether the tumor cells are dividing, whether it's viable, or the cells are growing. So, and the biopsy at 6 weeks may not be the same as 10 weeks or 12 weeks or 13 weeks, because we know that pathological complete response post chemoradiotherapy continues beyond 6 weeks. It can continue even if you do not actually, as we saw earlier, even if you do not intersperse it with the full chemotherapy. So how should we monitor patients who we think on MRI have an MRI TRG 1 to 2? You can do a clinical exam and also do serial MRIs. I usually tend to do MRIs at 3 monthly intervals. And to begin with, I would see the patient at monthly intervals. The other thing I find very useful is in all my colorectal patients, I do a baseline CEA and CA19-9, because some of our patients may have a CEA which is raised, some may have a CA19-9 which is raised. So whichever is raised, I actually follow that up to begin with at monthly intervals, and after that at 3 monthly intervals, especially if I am if you're trying to avoid surgery and avoid a stoma in that patient. There is some very good data actually with the liquid biopsies or circulating tumor DNAs, which if it is raised or with the rate of fall and then rise predicts for local recurrence. And this is something which I mean, if it's quite expensive, which can be followed up. So I think important that, assess your surgical plane and also do YM, which is, post, we do YP for pathology staging. So do a YM post completion of neoadjuvant chemoradiotherapy staging to see, if it can predict for complete clinical response. Again, for that, you need to be working with a good radiologist. So coming on to the second part of our talk, which is total neoadjuvant therapy, what is our aim is to avoid surgery. Can we facilitate organ preservation as the main aim? And can we avoid chemoradiotherapy? Because we discussed last time, and I'll discuss it more in detail, because radiotherapy, pelvic radiotherapy does have long-term side effects. Also, one of the aims of total neoadjuvant therapy is whether we can avoid adjuvant chemotherapy, because the compliance with adjuvant chemotherapy is very poor in patients who've undergone neoadjuvant therapy followed by surgery. So about almost 40 to 60% patients actually do not end up having adjuvant chemotherapy. So I think it'd be good to, same argument is there in pancreatic cancer and gastric cancer and all the other solid tumors as well, that you want to try and give effective treatment first rather than post-op when the patient may be too unwell to receive the treatment. We discussed some of these trials. The radiotherapy first trial is the timing trial, and then you have the Polish trial as well. You have total neoadjuvant therapy, you can have chemo first or you can have radiotherapy first. So if you look at the radiotherapy first trial, the Polish trial was quite ugly or bad tumors. These were fixed T3 and T4 tumors which were locally recurrent. They got short course radiotherapy followed by 3 cycles of FOLFOX given at 2 weekly intervals, versus long course chemoradiotherapy. The interval was identical, after which they had TME, and the endpoint was the radical, the R0 resection rate. And as you can see, the R0 resection rate is pretty much similar in both the arms. It is not significantly different. Though with the long course, you have increased toxicity, significantly increased toxicity. PAT-CR rate was not significantly different between the two arms. Similarly, if you look at the long course study, the Spanish study, patients had chemotherapy for 4 cycles followed by long course, versus long course followed by surgery followed by adjuvant chemotherapy, poor risk rectal cancer patients. And as you can see, with total neoadjuvant therapy, there was better compliance to full chemotherapy, 94% versus 60%, and also lower toxicity, 50% versus almost 19%. So significant difference. So why would you not go for total neoadjuvant therapy? Now, these were the phase 2 studies, which then led on to the phase 3 trials, which we'll talk about. So total neoadjuvant therapy, this was the norm, long course chemoradiotherapy followed by adjuvant chemotherapy. Then, like I said, about 20 to 70% do not actually end up having systemic chemotherapy. So I think what we're trying to do is bring it forward, and so that most of our patients, like you see, 94% patients end up having the treatment. So these are the various ways you can use it. There are a few trials with NACT or neoadjuvant chemotherapy alone as alternative to radiotherapy, which I won't discuss today. The Chinese FOAC trial is discussed, has been published, but again, the numbers were not big enough. The Prospect trial with FOLFOX has completed accrual, and hopefully we'll see the results very soon. The preliminary findings with the neoadjuvant chemo alone show a path response rate of about 26 to 29%, which is quite impressive. So this was discussed at ASCO just last month. The Rapido trial, again, MRI-based entry criteria, T4, EMVI positive, N2, CRM positive patients. So these patients had bad tumors, were randomized to short course followed by Kpox times 6 versus long course chemoradiotherapy. And then they had a TME. There was the PRODIGE 3 trial, which was again pretty similar, but the patients were randomized to FOLFOXIRI. It's the same as FOLFIRINOX that we use for pancreatic cancer, followed by long course chemoradiotherapy. Now, the Rapido was a short course trial. This was a long course trial versus long course chemoradiotherapy. And then they had a TME followed by adjuvant chemo for 6 months. So the Rapido, both the trials have actually shown that TNT is significantly better. That's the bottom line. So as you can see, patients who in the Rapido trial, about 24% versus 30% disease treatment related treatment failure. The PAT-CR was significantly higher in patients who had short course followed by chemotherapy versus chemoradiotherapy. And if you compare it to the Polish trial we just discussed, you can see the PAT-CR rate was 16% in the Polish study, and here it's about 28%, slightly higher. But you also see that though these are both phase 2 and phase 3 short course trials, the design is almost similar. The number of chemo cycles is more in the Rapido trial, and also the interval to surgery is slightly longer. Hence, the PAT-CR rate is higher. The PRODIGE 23 study, which was again a long course chemoradiotherapy along with FOLFOXIRI given before that, also showed that disease-free survival was significantly better with total neoadjuvant therapy. PAT-CR rate was almost double with FOLFOXIRI followed by CTRT, 28% versus 12%, no difference in health-related quality of life. Now, all of these studies sadly have not shown any benefit on overall survival. And I think that is related to the fact that we have good salvage options available for these patients when they recur. The other question that was looked at is the sequence question, whether you should give chemo first or whether you should give chemoradiotherapy first. And in the OPRA study, patients were randomized to chemo followed by long course chemoradiotherapy versus long course followed by chemo followed by surgery. And entry criteria pretty standard in distal rectal cancer patients. Primary endpoint was 3-year disease-free survival. This was also looked at, if you remember, in the German trial, which was published last year. Again, here you have 3 cycles of FOLFOX followed by long course versus this, and the primary endpoint was pathological complete response rate. The differences in the 2 studies are intensity of oxaliplatin is different, duration is different, dose of radiation is different. So I think it's like comparing apples to oranges. Interval from chemoradiotherapy to surgery was also different. And basically the point was to see what is the organ preservation rate, organ preservation rate or pathological complete response. As you can see, if you look at this slide, the rate of path CR in OPRA is 43% in chemo first versus 58% in chemoradiotherapy first. Versus if you look at the German study, but again, like I said, these studies, the entry criteria was different and a lot of the chemo and dose of radiation were very significantly different. But this basically shows possibly upfront chemoradiotherapy followed by chemo appears better than reverse sequencing in neoadjuvant therapy. Now, just very briefly about toxicity of radiotherapy. You have, so I used to do a proctitis clinic at the Marsden with Professor Jarvis Andreev, and it was quite distressing to see the patients who, with anal blood loss, with fecal incontinence, and unintentional release of stools, which is quite high. And also there is a risk of second cancers, which is increased. So if you look at anorectal and sexual function with pre-op radiotherapy and TME versus TME alone, all of these papers show that, you know, it's worse with pre-op radiotherapy. Also, if you have a patient who's had a low anterior resection, it's important to ask just these 5 questions. You know, how often do you open your bowels? Do you ever unintentionally pass flatus or liquid stool? And you will find that, you know, there are quite a few patients who have no LARS, minor or major LARS, and major LARS was significantly higher in patients who had pre-op chemoradiotherapy and surgery versus surgery alone as well. Prospect trial, we're not going to talk about, I've already discussed this. So what about adjuvant therapy? I think again, I will not go into the details because it's again a long lecture in itself. We discussed that we have extrapolated most of the rectal studies from colon cancer. There have been adjuvant trials in rectal cancer and quite a few of them have not shown benefit, but most of those studies were underpowered to detect a benefit of adjuvant therapy in rectal cancer. And if you see this slide, impact on overall survival, if you look at 6 methods, surgery alone or surgery and radiotherapy, so the survival is significantly worse here at the bottom. But if you look at the top 4 curves, which have chemotherapy in it, the survival is significantly better. So again, oxaliplatin adds benefit based on the colon studies in locally advanced colon cancer, MOSAIC and the NSA-BP. They've compared it to 5-FU fluoropyrimidine alone versus fluoropyrimidine oxaliplatin. And the genomic database supports rectal and colon cancers having very similar genetic makeup. So I think it's all right to interpret the colon cancer data. The other question I think all of you have and all that we also think about, that patient has had a path CR. Do we really need to give chemotherapy? And I debated this with a colleague of mine a while ago, and I debated for no chemotherapy actually. And as you can see from this slide, that they have an excellent prognosis, you know, with patients who have a YPT 0 to 2 compared to those who are T3 and 4. It's almost above 90%. And, you know, if you look at the patients who had adjuvant chemotherapy and who didn't have adjuvant chemotherapy, you see the curves are pretty much similar. So whether we really need to give adjuvant chemotherapy, we don't know. But I think most of the time we go by pre-operative staging and offer patients chemotherapy, if not 6 months, at least 4 months. The other question is whether you should give capecitabine versus 5-FU. This study was randomized, showed non-inferiority of capecitabine over 5-FU. But as you can see, that capecitabine curve is slightly on top, so looks slightly better, the red curve. I think to conclude, to deliver the best in rectal cancer care, we need high quality MRI. It's very important you question your radiologist and make sure that the protocol is right. And they do synoptic reporting of all the parameters that you need, because it will help you make the right decision for your patient. Surgeons who perform high quality TME, very important, have your own benchmark, assess your own. So for all the chemos that I do, I have a prospective database. I look at the response rates. If I change the trusts or hospitals, survival may not be available, but at least response rates. Similarly for surgeons, you must know what the quality of your TME is, know what your local recurrence rates are, know what your nodal yield is, and have a pathologist who photographs and scores the specimen so that you can assess the quality of specimen if you really want to have a curve that is going exponentially up. So if the CRM is threatened, for sure, that is a very hard indication for me, is pre-op treatment is indicated. Now, whether you give short course and long course, they are both acceptable. Short course and consolidation chemo is also acceptable, as was seen in the Rapido study. Neoadjuvant chemo does impact disease-free survival, but not overall survival in any of the trials that we've discussed. Now, we still don't know whether we give more chemo and longer interval for better response. And as far as chemo is concerned, you had PRODIGE 23, which had FOLFOXIRI. You have PROSPECT, which is FOLFOX. So the question is whether you should go all out, or you can get away with FOLFOX, because we know that FOLFOXIRI is quite toxic and does need GCSF support for all patients. So I would like to acknowledge, I've borrowed some of the slides from Professor Gina Brown and Rob Glyn Jones. Thank you. So we can have questions now, and I have some questions already. So let us see. Is there a role of combining MRI with biopsy if non-operative management is being followed? So, it's like the Dr. Habergama's data is she did do biopsies, but in the TRIGGER study, which is being done in UK, where we are randomizing patients and trying to see whether, we are doing MRI TRG, tumor regression grade scoring, to see whether this approach can become standard of care. I don't think that they're doing biopsies at all, because like I said, if you do biopsy at 6 weeks or 12 weeks, you don't know. Even if you see cancer cells there, you don't know whether they are alive or dead, or whether they have the potential to divide. Because we know that even if you don't give chemo in between, the impact of radiotherapy can continue for 6 weeks, 7 weeks, and even 11 weeks, as we saw from the Grecar study. So the further you get away from radiotherapy, the more likelihood you have of pathological complete response. So I would not do it with biopsy. I would just do a clinical exam, MRI, and CEA or CA99 is my standard of care, and quite a few others as well. Then what is the fraction of patients who have disease progression on neoadjuvant treatment? So again, it's different with various studies. Even stable disease is not good in ugly tumors, because they end up having an APR. And so I would say it's about, in different studies, it's about 10 to 20%. And usually I have seen that these are the patients who have a signet ring histology, in my experience, and young patients with resistant tumors. Any other questions? So it's great to see you all. If you're not part of my group, the teaching group, let me know. I will add you to the WhatsApp group so that the Zoom invite can be sent to you. How does location of the tumor in the rectum change management? I think we discussed that last week. I will share the slides. No, I think I've already shared it with you guys. So basically, if it's an upper rectum tumor, you would treat them as colon cancer, and we discussed some of the studies which showed that. So it's above the peritoneal reflection, you would treat them as colon cancer. But if it's below the peritoneal reflection, you would consider a TME. And if it's a low rectal cancer, you would consider some form of neoadjuvant approach. Your threshold to have a neoadjuvant approach would be higher, especially like I said, you know, if you have CRM positivity, EMBI, or T3C or T3D, or N2 or node positive tumor. But if it's a T1, T2, then upfront node negative, CRM not involved, EMBI negative, then upfront surgery should be the option. But if you have a low rectal cancer, you do not have any of these, but the patient wants to avoid a stoma, then one can consider a total neoadjuvant therapy type approach to see if they attain a complete clinical response. And we've done that with a few patients where the patients have said, I mean, they've used very aggressive terminology as to, you know, they cannot live with a stoma. They will not. I would rather die, they said, than have a stoma, some of the patients. So I think that gives you time to actually counsel the patient as well and work with the patient to get them around to a stoma. What I normally do is I get them to talk to patients who have a stoma. So I have quite a few young patients who have a stoma. I have a patient who had a stoma when she was 25 years old, and now she's become an amazing patient advocate. And I get her to speak to some of my patients. You know, she's got married after that. She has a normal life. The stoma is her friend. So I think to begin with, everybody is anti-stoma, and none of us would want a stoma. But I think you need to give patients time to come around that, and sometimes that neoadjuvant therapy might help you do that. And also, you know, if the patient is very symptomatic with a low rectal cancer, giving chemotherapy like Folfox, I usually prefer Folfox because we are never able to achieve the doses of capecitabine in India as the Western data recommends. So then patients, you know, within a week feel completely relieved. They don't bring a tube when you see them in the OPD. They come and sit on the chair. They are not uncomfortable. The anal spasm is better. So, you know, I sometimes, rather than go for chemoradiotherapy, I give them just one cycle of chemotherapy, and then they go for chemoradiotherapy. Then location. So ideal time to operate after completion of chemoradiation. So, you know, we discussed the Grecar study, 7 versus 11 weeks. 11 weeks, the surgical morbidity was significantly higher. But, you know, if I speak to all the surgeons today, and Shabnam is here. Okay, Shabnam, you can also take this actually, or any one of you can if you are a surgeon. They don't see any issue with operation based on the interval. What I tend to do, my practice is after a patient has had long course, I tend to do an MRI about 6 to 7 weeks later. And if the CRM, let's say, is still involved, I'll give them chemotherapy and try and downstage them so that the tumor is lifted off the CRM and the CRM becomes negative before they go for surgery. But if the MRI grade is TRG 1 to 2 or even 3, then they would go for surgery. But if the MRI TRG remains 4 to 5, I would do something else to downstage even further before they go for surgery. So then, Shabna, have you compared OS between anterior versus posterior or lateral? So, you know, we discussed, I think the anterior tumors tend to do worse compared to the posterior tumors subject to the same, and they are more likely to have. We discussed last time that the chances of CRM positivity are significantly higher in anterior tumors. Would you agree? Yes, 10th to 11th week is the best time. Beyond 11th week, sometimes there's a lot of fibrosis. Yes, okay, that's great. Then your experience in interpretation of MRI after long course. Is MRI TRG used commonly in India? Yes, I think you should read Dr. Suprita Arya's papers from India. She's the Gina Brown of India, I say. She's fantastic. So read her papers. Yes, MRI TRG is, if it is not used, speak to your radiologist and get them trained. And at least at Max, I have amazing Dr. Bharat Agarwal, who does give me the TRG if I ring him and ask him. It is not routinely used because we tend not to use synoptic reporting. We will add, complete response, partial response. We still use those terms. But I think if all of us drive it in our practice and push our radiologists who are always willing to, help you, they would report the TRG. So I think